and welcome to this month's podcast, where we will bring you up to date with the latest information in axSpA. In today's podcast, I'm joined by Professors Hideto Kameda, Atul Deodhar, and Xenofon Baraliakos, and we will be reviewing papers in which several of us have been involved. We will discuss the long-term safety and sustained efficacy of five-year results from the BE-AGILE trial and its open-label extension. And we will also discuss the long-term safety and efficacy of Bimekizumab 2-year results from the BE-MOBILE 1 and BE-MOBILE 2 trials. To access detailed summary slides for the papers that we discussed today, please visit the imidforum.com. So Atul, please, over to you for the first paper.
Thank you. I'm going to discuss the first paper, which is long-term safety and sustained efficacy of Bimekizumab in patients with ankylosing spondylitis, also called radiographic axial spondyloarthritis. These are 5-year results from BE-AGILE, which was a phase 2b study, and its open label extension. So patients with radiographic axial spondyloarthritis exhibit definite structural damage to the sacroiliac joints on the radiographs, and that's how we differentiate them from non-radiographic axSpA. And the condition can result in chronic pain and functional impairment, reducing the health-related quality of life. IL-17A, tumor necrosis factor, and JAK inhibitors are recommended as effective targeted therapies in patients with axial SPA. Bimekizumab is a monoclonal IgG1 antibody that selectively inhibits IL-17F in addition to IL-17A. It's the first monoclonal antibody targeting both IL-17A and IL-17F approved by both the EMA and the FDA in axial spondyloarthritis. This study reports the safety and efficacy data up to 256 weeks of Bimekizumab treatment in patients with radiographic axial SPA across the BE-AGILE study and its open label extension. So the results show that 95.4% of patients experienced at least one treatment emergent adverse event, or TEAE. Most common TEAEs were nasopharyngitis, which was close to 22%, upper respiratory infection, close to 15%. The exposure-adjusted incidence rate, which to me is more important, of serious infection was 1.4 per 100 patient years, with no cases of active tuberculosis. This is an important number, 1.4, to use in our daily discussions with our patients. At week 256, nearly 50% of the patients achieved ASAS-40 response with the non-responder imputation method, and about 42% achieved the ASDAS low disease activity, also by the non-responder imputation. Mean ASDAS improved from 3.9 at baseline to 2.1, which is the cutoff for low disease activity at week 48, maintained to week 256. Nearly 67% of patients completed the study by week 256. So in conclusion, the safety profile of Bimekizumab after 5 years of treatment remained consistent with previous reports. There were no new safety signals, and 5-year efficacy was sustained in this radiographic axial SPA population following a robust disease control that was achieved at week 48. So I would like to hear from our colleagues as to what they think about it. What do you think, Hideto?
Okay, thank you, Atul. So this is very comfortable for the prescribing the bimekizumab for axSpA patients. And I want to consider the time course of the adverse events for early phase and later phase. So for oral candidiasis, it was seen in the early phase rather than later phase. And in contrast, for psoriasis or anterior uveitis, it was observed in later phase, not frequent in early phase. And very interestingly, for IBD, it was observed in early phase, so within 48 weeks, and also in later phase. So I think that oral candidiasis was a partially bimekizumab induced. And for psoriasis and anterior uveitis, we know that bimekizumab treatment is rather preventive for the development of these symptoms. And for IBD, I feel rather neutral by bimekizumab. So what do you think about this, Atul?
So I'll let the others speak as well. I think you made a very important point that when you do a 5-year study, we are always interested what happens in the first year and the second year and the third year, 1 to 2, 2 to 3, 3 to 4. And that's the power of doing a study this long. And you're correct that the oral candidiasis that generally occurred in the first year, and that is something that we can tell the patients that if you stay on this, and usually candidiasis would occur early on, but later on somehow it doesn't occur. Now there is a little bit of caveat here, is that 67% of the patients completed the study. So there is always a possibility that those who dropped out were the ones who had severe candidiasis, and that's why they came out of the study early on. And that's why the people they are self-selected to stay long term. Having said that, we did look at this part as well as to how many people came out of the study because of the adverse events, and that number is very, very low. And all this, of course, for safety assessment, any patient who has received a single dose of bimekizumab are included. For efficacy assessment, this is the non-responder imputation, which also I think is very unusual. I don't know of any other study where for 5 years non-responder imputation was used. Not generally, almost always, it is observed cases by that time. And but thank you for raising the point about year to year. Important thing we need to look at.
Yeah. Okay, thank you. And over to you for further discussion, Sophia.
Thank you very much, Hideto. I totally agree with what both of you have said before, and will not repeat that, of course, but I think it's important to emphasize that indeed we are seeing here reassuring data in terms of efficacy and in terms of safety. And of course, not surprisingly, we are focusing on an adverse event that is more typical for bimekizumab compared to other drugs. So indeed, we see more oral candidiasis than we do see with other drugs. But Atul made a very important point that I would like to emphasize, is that we indeed looked into how many patients have discontinued bimekizumab due to oral candidiasis, and none of the patients that had discontinued did so because of oral candidiasis, and the patients that had oral candidiasis did not need to discontinue the drug, which I think is important. So of course, it's an adverse event that we would rather not have, but the patients that experienced it, even in the context of a trial, could continue on their trial medication without the need to stop it. So we're talking about mild infections that do not require discontinuing the treatment, which I think is helpful and reassuring for our daily clinical practice as rheumatologists. And indeed emphasize what Atul also mentioned in terms of efficacy, because we have long-term data. We have a very conservative way of analyzing the results with a non-responder imputation, and still we have good data and encouraging data on a long-term efficacy. So I think it's very good that we now have this additional option for our patients. Don't know if anyone has any other comments on this first study, although our discussion will continue on the same topic in the second, so we may also want to continue and then continuing the discussion on the same topic.
Should I continue?
Yes, go ahead, Xenofon.
Yes, I'm happy to do that. And in fact, I did not add anything to the discussion because it was really complete to me, and I think there's nothing really to add. We discuss further bimekizumab, we discuss further axis spondyloarthritis. As mentioned in the beginning, it's now the long-term safety and efficacy of the 2-year results from the 2 phase 3 studies that we're having to also put into this context. And I would like to remind everyone what we just discussed. We have bimekizumab as a compound that demonstrates efficacy and has been very good tolerated in up to 1 year in not only radiographic axis spondyloarthritis or ankylosing spondylitis, as Atul mentioned before, but also in the non-radiographic axis spondyloarthritis in studies that have been run in parallel. This means they are called BE-MOBILE 1 and BE-MOBILE 2. The study that I'm presenting here is interim 2-year data from the BE-MOBILE studies just mentioned, and their combined ongoing open label extension. That study is called now BE-MOVING. It assessed the long-term safety and efficacy on bimekizumab in axial spondyloarthritis. I remind you, we have phase 3 data here, and we have now, of course, because we go on the long-term safety as a first primary thing to discuss. So 2 years data, over 50% of the randomized patients achieved ASAS40, which is in fact the continuation of what we've seen so far, and this means significant improvement in their condition as compared to when they started. Approximately 60% of these patients reached low disease activity according to ASDAS, that's a score below 2.1, and more than 1/3 achieved ASDAS inactive disease. This means, in fact, remission, but we call it inactive disease in this case. Improvements in clinical outcomes were sustained from week 16 on through week 104, with high levels of improvement in pain, morning stiffness, fatigue, and also function. In this open label extension phase, about 71%, 70.8% of patients reported at least one treatment emergent adverse event, and the most common was, and by the way, including COVID-19 infection, was nasopharyngitis and oral candidiasis, as mentioned before. So we have, in fact, a confirmation of the safety profile overall. The nasopharyngitis was 11 emergent events per 100 patient years, and the oral candidiasis was lying at 5.4. The rates of inflammatory bowel disease and uveitis were low. There was no major cardiovascular event or any death reported. And bimekizumab demonstrated sustained suppression also of objective signs of inflammation, such as the ones seen on MRI, with over 57% of patients achieving remission at MRI at week 104. The improvements in the MRI inflammation, by the way, were observed at week 52, and they were maintained through the entire open label extension as reported here. So overall, also here in these phase 3 studies, bimekizumab demonstrates a favorable long-term safety profile over 2 years. It's consistent with observations from the BE-MOBILE studies, the previous phase 2b studies in radiographic axial spondyloarthritis, and the phase 3 studies in other indications. And it's important again to know what we're discussing here. We're discussing a compound with a dual inhibition of IL-17A and F, also mentioned by Atul in the beginning, which resulted in a sustained efficacy through 2 years, with improvements overall in disease activity, in patient symptoms, in health-related quality of life, in physical function, and also in objective signs of inflammation, such as the ones observed on MRI consistently across the full spectrum of axial spondyloarthritis. And again, the safety profile was consistent, and the long-term maintenance of clinical response provides a robust evidence that supports bimekizumab as an important treatment option in patients with axial spondyloarthritis, which we all very much need, obviously not because we have too little or too few agents, but because we do need more in order to capture more patients adequately over long periods of time. Well, I know I might have been repeating a couple of things, but I think it is important to, as also mentioned before, have seen them in the larger amount of patients and in the more, let's say, robust cohorts that we are seeing. And phase 2b's, as discussed in the beginning, are important, but phase 3 are the ones that also the agents are referring to. EMA and FDA, was also said before, are also looking at this data. In fact, the next question is, what do we expect from daily practice? And we are all using this drug. I think in the meantime, it would be nice to really see if there's anything that you would like to point out of this data, of this other than mentioned, or if you believe that daily practice is maybe even different or exactly the same.
Yeah, I think I'll jump in. I think this is a very important question you raise, Xenofon. And whenever I present this data in my talks here and there, people say, where does it fit in our daily practice? Where would IL-17A plus F fit? Would it be a first line agent, or would it be a second line, or would it after IL-17A has failed? And that's the reason why these kind of studies are important, in the sense that we at least know what the safety is of this completely new molecule. That is something that we need to know. That's something that we need to be reassured of, because we are blocking a second cytokine apart from IL-17A, IL-17F, the second cytokine we are blocking, and we have to explain this to the patient, and we need to be comfortable with. And I have thought about this, for some time, and I think this is, as at least on the paper, it looks better than IL-17A alone. However, in practice, in my experience or whatever I use this, it looks pretty similar to IL-17A, which is quite an effective way of treating axial spondyloarthritis patients. And Sofia was the first author on the ASAS-EULAR recommendations recently, and there they have put IL-17 inhibitors, quote unquote, all of them, along with TNF inhibitors as the first biologic. And I would agree that this would fit there. So to me, whether to choose TNF inhibitor or IL-17A inhibitor or IL-17A and F inhibitor depends upon the patient's condition. So for example, if there is significant amount of psoriasis, then yes, then we would use this. Whereas if there is significant amount of IBD, of course, we will go towards TNF inhibitors. But one other reassuring thing, which Hideto mentioned earlier, was about the uveitis part. And it appears that the risk of uveitis is not that different from what we have seen, the risk of uveitis in TNF inhibitor, well, I should say the monoclonal antibody TNF inhibitor studies in axial spondyloarthritis. It's pretty similar. There is no head-to-head comparison, but if you look at the exposure-adjusted incidence rate, EAIR, of acute entry uveitis per 100 patient years, very similar in this study compared to, or these studies, I should say, on Bimekizumab compared to TNF inhibitors. So anyway, long-winded answer, but I think this would fit exactly the same place where TNF fits and IL-17A fits, another agent which would fit exactly at the same spot. Individual decisions we always make in the clinic based on the patient's personal risks or extra musculoskeletal manifestations.
With the one, I wouldn't call it exception, but maybe add on, that we have seen in daily practice patients responding to the one, not responding to the one IL-17 inhibitor, but responding to the other one, and vice versa, I have to say. This very much means that obviously we do need additional drugs, maybe even, let's say, of the next generation, if we call Bimekizumab as the, let's say, IL-17 inhibitor 1.1 and not 1.0, because simply because we've seen these patients, again, going both ways. So I think we urgently need even more of those drugs to really find out what is best, the best fit for which patient. That's something I think we will maybe have to solve in the next couple of years.
I totally agree with what you have said, of course, and just to say that indeed we would love to know which is the patient that benefits most from one type of drug or the other type of drug. Atul already mentioned several patient characteristics that point us towards one drug more than the other. It would be good to know which patients respond better to IL-17A and F than to IL-17A inhibition. We do not have those data in patients on a trial level, at least, and we will accumulate that evidence from daily clinical practice. There seem to be similarities, as Atul was mentioning, which is not strange. It's a common mechanism of action, although there's a further inhibition with Bimekizumab. On the other hand, we have a different characteristic in what concerns the effect on uveitis, as was already mentioned, which we do not see with the IL-17A inhibitor, especially before. So the data are promising, although I think we also have to acknowledge that it's still short-term data. We do not have yet on very large number, very long-term data, but what we have is very promising and different to what we had from previous IL-17A inhibitors. So indeed, it's now with the use in daily clinical practice and with accumulated data from registries that we will learn more about the specificities of this new drug that we have available for our patients. Any other comments from anyone?
I want to make another quick comment, and this isn't always a interesting thing for me when I look at these long-term studies. I'm going back to the first study, the 5-year-long phase 2B study, BE-AGILE. if you look at and of course, in long-term studies, we are also very interested in looking at the status of the patient, not this change measures 20%. But if you did look at ASAS20, 85%, this is as observed, which is the most lenient way of looking at things. ASAS20 response was 85%, which means 15% of the patients still stayed into the study, and their ASAS response was not even 20% less at the end of 5 years. So why do these people stay in the study? And this has always been a curious thing for me, that patients, there's something, I mean, either and I would like your opinion about that, either our measures, ASAS20, ASAS40, ASDAS, they are not really capturing. I looked at BASDAI 50, and BASDAI 50 is about 70%, 75% in, again, as observed at the end of 5 years, which means 25% of the patients, their BASDAI was not below 50%, but they still stayed in. There is something that people like about being in an environment where they come regularly, they see the doctor, they see the research assistant, and just gives them some solace, I want to say, which is we are not measuring somehow. I mean, I can't think of anything else, but there would be some people, at least in the US, who stayed in the study because they had lost their insurance, and this is the only way they're getting the drug. And that could be one of the reasons why they stay.
I can say something to that, because I think this is an extremely interesting topic we always discuss.
Yeah.
And we recently had some data published out of pretty many, let's say, thousands of visits. And I mean, I know that our data, but I guess others have seen the same thing. I think that what we measure is partly what's happening, as you just mentioned. We have to ask the patients, how are you doing and how do you feel as compared to your initial state? And there are patients who are not even ASAS20 responders, including the ASAS40 and so on, who still felt as being in a very good status. So what we're measuring is the measuring of the improvement of the questions, but how the patient is feeling may be different. So there's data out there showing this, as you say, and obviously, yes, there might be also insurance issues and other reasons for different incentives for both patients and physicians keeping the patients in the study, but I guess that most of them have felt better.
So, what you're saying is our ASAS20, ASAS40, ASDAS, they are not measuring this well-being.
Well, you can say that indeed, that partly this is not happening because obviously patients respond based on how they've started and they feel much better, and this is maybe already good enough for them. But what is not captured there is how high we can go, though, with our treatments. How high means how good we can become. So yes, there is a dissociation between what ASAS and ASDAS and BASTA is capturing, whatever other measure you may think of, as compared to what some patients feel that is not being captured by these questions. And again, this is data that can be seen now, and I think this is important to remember. And I think this is a response to this indeed very important question.
Yeah, totally agree. And maybe also adding to the reasons you already mentioned, because indeed for some patients, there are not other better options and therefore they stay in the trial. But others, it's also that the disease fluctuates. So at the moment where we have the last measurement, they were not meeting ASAS20, but that does not mean that they never met ASAS20. So it can be just that moment that they are a little bit less well and they have been better before and they eventually will be better afterwards. So it fluctuates a bit and there's no, it's not a white or black, black or white every time, of course. Okay, great. I think this, any other comment, Atul, you were going to add something? No? Okay, so I think this is bringing us to the closure of this podcast. So to view the full publications uploaded this month and to access our other podcasts and resources, head over to the imedforum.com. Don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure that you don't miss our podcasts in the future. And as always, make sure to let us know what you think by leaving a review. And thank you for your attention. See you next time.